Episode 4, Senescent Cells, the zombie cells that age the body. Hey, it is Adam Sewell, MD. Today, we are starting one of the most important sections in the entire biological age reversal series. We are talking about cellular senescence. This is one of the most powerful drivers of accelerated aging and one of the most reversible when you understand what is actually happening at the molecular level. Senescent cells do more damage than almost any other aging mechanism. They create a toxic microenvironment inside tissues, they slow healing, they amplify inflammation, they alter stem cell behavior, and they spread their dysfunctional state to cells around them. If you want to reverse biological age by 20 to 30 years, you cannot skip senescent cells. They must be cleared, and the earlier you intervene, the easier it is. Let us begin. Section 1. What senescent cells are. A senescent cell is a cell that has stopped dividing permanently. It is not dead. It is not functioning normally. It is stuck in a limbo state. It cannot progress through the cell cycle. It cannot complete normal metabolic tasks, and it cannot be cleared efficiently by the immune system. Senescence originally evolved as a protective mechanism. When a cell experiences damage that could lead to uncontrolled division, such as excessive DNA damage or oncogene activation, the cell enters senescence to prevent cancer formation. This is why senescence is not always harmful in small amounts. It is a protective shutdown. But as we age, the number of senescent cells increases. They accumulate in fat tissue, joints, muscles, tendons, the skin, blood vessels, bone marrow, and even the brain. In youth, the immune system efficiently removes these cells. In aging, immune surveillance declines. Senescent cells begin to accumulate faster than the body can clear them. That is where the trouble starts. Section 2. What makes senescent cells dangerous? What makes senescent cells uniquely damaging is the fact that they secrete a constant flow of inflammatory molecules. This mixture is called the senescence-associated secretory phenotype. The senescence-associated secretory phenotype includes cytokines, chemokines, proteases, and reactive oxygen species. Some of the key cytokines include interleukin-6, interleukin-1 beta, tumor necrosis factor alpha, and granulocyte macrophage colony stimulating factor. Senescent cells also release matrix metalloproteinases that break down collagen and extracellular matrix. This secretory phenotype acts like a toxic fog inside the tissue. It increases inflammation, it damages healthy cells, it pushes nearby cells towards senescence, and it interferes with repair. Senescent cells shut down division in themselves, but they do not shut down messaging. They message constantly, and the message is inflammatory, catabolic, and destructive. This was described beautifully in a paper by James Kirkland published in eBiomedicine in 2018. They demonstrated that senescent cells secrete bioactive molecules that accelerate aging, and that removing these cells in animal models increases health span and improves physical function. Section 3. How senescent cells form. Senescent cells form when a cell experiences too much stress or damage. The most common triggers include telomere shortening, mitochondrial dysfunction, reactive oxygen damage, DNA replication errors, radiation exposure, chemotherapeutic injury, metabolic stress from obesity or insulin resistance, and chronic inflammation. There are two main types of senescence. The first type is replicative senescence. This happens when a cell divides too many times and its telomeres become critically short. Telomere shortening triggers a DNA damage response, and the cell enters permanent arrest. The second type is stress-induced senescence. This is far more common in aging tissues. Here, the cell stops dividing not because it has reached its natural limit, but because it has been exposed to excessive oxidative stress, toxins, chronic inflammation, or mitochondrial failure. In modern medicine, the second type overwhelmingly dominates. This means that senescence is not really a chronological problem. It is a stress problem. Patients with chronic inflammation and high oxidative burden accumulate senescent cells far faster than healthy individuals. That is why you see 40-year-olds with senescent burdens that look like a 70-year-old. Section 4. Where senescent cells accumulate in the body. Senescent cells do not accumulate uniformly. They concentrate in areas of chronic stress. Fat tissue is one of the biggest reservoirs. Senescent fat cells release enormous amounts of interleukin-6. That is why obesity accelerates aging. Joints accumulate senescent chondrocytes, synovial cells, and fibroblasts. These cells release matrix metalloproteinases that break down cartilage. This is one of the root causes of degenerative joint disease. Muscles accumulate senescent satellite cells. These are the stem cells responsible for muscle repair. When these stem cells become senescent, muscle tissue cannot regenerate properly. That leads to sarcopenia and frailty. Blood vessels accumulate senescent endothelial cells. These cells lose their ability to regulate nitric oxide. The result is stiffness, hypertension, and vascular disease. The immune system also accumulates senescent T cells and senescent natural killer cells. When the immune system itself becomes senescent, the body loses surveillance and repair capability. Even the brain is affected. Astrocytes and microglia can enter senescence. When they do, they lose their ability to support neurons and instead become inflammatory. Section 5. Clinical signs of senescent cell burden. One of the first clinical signs of elevated senescent cell burden is delayed recovery. If a patient says, "Once I flare, I'm stuck for days or weeks," that is a senescence pattern. Another sign is diffuse pain that does not map cleanly to anatomy. Senescent cells create systemic inflammation that amplifies pain signals. Patients may also experience increased stiffness, slower wound healing, frequent viral reactivations, chronic fatigue, and general loss of resilience. In the skin, senescence shows up as thinning, reduced elasticity, and slower turnover. In joints, senescence presents as consistent swelling, crepitus, and pain, even with minor mechanical load. Another sign is metabolic inflexibility. Senescent fat cells disrupt insulin signaling, leading to glucose instability. Clinicians often misdiagnose these patterns as simple chronic inflammation. In reality, senescent cells are driving that inflammatory load. Section 6. Why senescent cells matter for biological age. Senescent cells accelerate every major hallmark of aging. They increase chronic inflammation, they impair mitochondrial function, they disrupt hormone receptors, they damage extracellular matrix, they worsen insulin resistance, they slow tissue repair, they impair immune surveillance, they interfere with stem cell niches, they propagate aging to neighboring cells. This is why the presence of senescent cells correlates strongly with epigenetic age. When the senescence-associated secretory phenotype rises, DNA methylation patterns shift toward an older biological profile. This was shown in multiple studies demonstrating that reducing inflammatory cytokines associated with senescence can slow methylation age drift. In other words, senescent cells are not a side effect of aging, they are a driver of aging. Section 7. Why clearing senescent cells can reverse biological age. When you remove senescent cells, several things happen immediately. Inflammatory signaling drops. Stem cell niches become functional again. Tissues regenerate faster. Mitochondrial efficiency improves. Nearby cells exit a state of stress. Hormone receptors become more sensitive. Insulin signaling improves. DNA methylation patterns shift toward a younger profile. This is why senolytic therapy is a pillar of biological age reversal. You do not need to remove every senescent cell. You only need to reduce the burden enough that the tissue environment becomes regenerative instead of inflammatory. This is what we see clinically after senolytic therapy. Patients often report better sleep, faster recovery from exercise, reduced pain, improved joint mobility, less brain fog, and better metabolic stability. Section 8. Why senescence is rising faster today than in previous generations. Modern life accelerates senescence. Chronic stress elevates cortisol and pushes cells into senescence. Diets high in sugar and seed oils create oxidative stress. Environmental toxins damage DNA. Sedentary behavior reduces autophagy. Poor sleep increases inflammation. Blue light at night suppresses melatonin, which is an antioxidant and mitochondrial protector. Even chronic infections, such as Epstein-Barr virus reactivation, can drive senescence. This is why you see 40-year-olds today with senescence patterns that used to appear in 60-year-olds. Section 9. Preparing for the senolytic trilogy. This episode sets the stage. In the next episode, we will begin the senolytic therapies, starting with the safest and most effective natural senolytics, including fisetin and quercetin. We will cover their mechanisms, dosing, evidence, timing, and expected outcomes. Then we will dedicate an entire episode to dasatinib. This is a powerful tool with serious risks. It must be used carefully, ethically, and only in specific patients. Senolytic therapy is not a fad. It is a scientifically grounded intervention with strong mechanistic support and growing human data. If you want to dramatically reduce biological age, senescent cells must be addressed. This is Adam Sewell, MD. I will see you in episode 5.